Right. Today, I have a great pleasure to present, to introduce the Professor Gisbert, and we say thank you to the Professor for accepting our invitation to this interview, which we hope will be of support to many colleagues that need to have some reference point in H. pylori infection. Please, dear Professor, can you give us a brief presentation about your professional career so our audience can get to know you better?
Good morning. So first of all, I would like to thank you for your very kind invitation. It's a great pleasure to share this interview with you. So I'm a gastroenterologist and also professor at La Princesa University Hospital in Madrid, in Spain. And I'm the head of the Inflammatory Bowel Disease Unit, which is an international reference center. And I'm also the Spanish representative at the European Helicobacter and Microbiota Study Group. And in this respect, I coordinate the European Registry on H. pylori Management, which is a large long-term registry of routine clinical practice by gastroenterologists involving 30 European countries and more than 300 investigators. Well, the first thing I would like to emphasize is that the infection is very, very frequent in the world. In fact, it is the most frequent infection all around the world, affecting approximately half of the world population. But it is not only important because it is frequent, but also because it is clinically relevant. So it is the main cause of gastritis, also peptic ulcer disease, and even more important, gastric cancer. So approximately 10% of the infected individuals will develop in the future a peptic ulcer disease, and approximately 1% of the patients will develop a gastric cancer. And all these diseases are quite clinically relevant because, for example, gastritis, which is very common, very frequent, may cause dyspepsia. The peptic ulcer disease can be complicated, causing a bleeding peptic ulcer, perforation or obstruction. And finally, we should always remember that gastric cancer is the fourth most frequent cancer in the world.
Thank you very much. What are the benefits of H. pylori eradication in patients with a peptic ulcer? So
I would say there are many benefits, many different benefits. So the first benefit, I would say, is the acceleration of the healing of the ulcer. So compared with the proton pump inhibitors to the anti-secretory standard treatment, when a patient receive an eradication treatment, the ulcer heals better and faster. I think another advantage, another benefit of H. pylori eradication treatment in these peptic ulcer disease patients is, and probably the most important, is that it decreases the recurrence of the ulcer. So you all know that anti-secretory treatment is quite effective in healing the ulcer, but the recurrence of the ulcer is the rule. However, when we eradicate the infection, the recurrence of the ulcer is almost null, almost 0%. I think there is a third benefit, which is the prevention of complications. Obviously, if we treat and cure the infection and we prevent the recurrence of the ulcer, we will be preventing also the complications as previously mentioned, bleeding, obstruction, or perforation. And finally, and at present, I think there is also a very important benefit, which is the reduction of the economical cost. And in this sense, and because the cost is, the main driver for the cost is the recurrence of the infection. Obviously, when we eradicate the infection, we will decrease this economical cost. So therefore, and I think this is the take-home message, not considering diagnosing or even treating the infection in a patient with peptic ulcer disease, I think should be considered a big mistake.
Thank you, Professor. What is, in your opinion, the best strategy in patients with uninvestigated dyspepsia? Test, treat, anti-secretory treatment, or endoscopy?
So I think that the first thing is to explain or to clarify what is non-investigated or uninvestigated dyspepsia, which, as you all know, is, I mean, the situation when we haven't performed the endoscopy and therefore we don't know which is the cause of this dyspepsia. So there are three different strategies or three different approaches for non-investigated dyspepsia. The first one is performing an endoscopy to all the patients. The second one would be to give an empirical anti-secretory treatment to all patients again. And finally, there is the so-called test and treat strategy. So the test and treat strategy means that we perform a non-invasive test, therefore we don't need to perform an endoscopy to diagnose H. pylori infection. And in case this test is positive, then we will prescribe eradication treatments. So the test and treat strategy has been demonstrated to be not only the best strategy, the most efficient, but also the most cost effective. And test and treat strategy is, I mean, is cost effective precisely in areas with mean, I would say, medium or high infection rate, which means higher than 10, 20%, which is the case in most of the countries. So finally, I would like to emphasize that test and treat should be used only in young patients. I mean, the term young could be quite delicate, but in most conferences, consensus conferences, the threshold is set at 50 years. So younger than 50 years, and also without alarm symptoms. Otherwise, an endoscopy should be performed to rule out the presence of a gastric cancer.
Thank you, Professor. And should eradication treatment be offered to every H. pylori infected patients?
Well, I think the response, the answer here is yes. And there are at least two types of arguments, of reasons to do that. The first is, I would say, an individual, a personal reason, but we have also public health reasons. So from the individual perspective, the infection, H. pylori infection is a risk factor, as we have seen, for the development of peptic ulcer and also gastric cancer. And therefore, even although the patient has no symptoms at the present time, he is at risk of having these complications in the future, peptic ulcer or gastric cancer. But as I said, there is also a public health reason, which means that the infected individuals by H. pylori infection, they constitute the main reservoir, the main source to the transmission of the infection. But anyway, I think we should inform in detail to our patients about the possible benefits, but also the risk, the disadvantages associated with the eradication treatment, and those, therefore, the patient could decide appropriately.
Thank you. Professor, what method we have to diagnose the infection of H. pylori?
Well, I think the diagnostic methods can be overall classified in invasive and non-invasive, depending on if they require the performance of a gastroscopy, of an endoscopy, to take gastric biopsies. So the first group is the invasive methods, and they include the rapid urine test, the histology, and also the culture. So the first one, the rapid urine test, is, as its name indicates, a rapid test and also very cheap. And therefore, I think it should be considered the method of choice if we need to perform an endoscopy. So the histology allows us to assess the presence of gastritis in the stomach, in the mucosa of the stomach. And finally, the culture allows us to perform the study of sensitivity against antibiotics, to know the susceptibility of the bacteria to different antibiotics. But on the other hand, we have, and this is also very important, the so-called non-invasive methods, including the urea breath test, the stool antigen test, and also the serology. So the urea breath test can be used, can be performed using the 13 carbon or the 14 carbon isotope. And obviously the 13 carbon is more appropriate because it's a non-radioactive radioactive isotope. Well, the stool antigen test can be monoclonal or polyclonal, and we should use the monoclonal one because the accuracy is higher. And finally, we have the serology. The serology is less accurate compared with this other non-invasive diagnostic test, and it should be previously validated locally, which is not the case in most countries. And finally, it's important to emphasize that this test, the serology, is not valid and should not be used to confirm the eradication. Because the 13 C-urea breath test, I think, should be considered the method of choice, the non-invasive method of choice to diagnose H. pylori infection. And there are several reasons for that. So the first one is that it has a very high sensitivity and specificity. I would say higher than 95%, so very high. There is a second reason, which is that it has a high reproducibility. This means that the results are very consistent and very homogeneous all around the world in many studies. And I think there are a third reason, which is that it's a very simple and safe test because it can be performed not only in children, but also in pregnant women. So the 13 C-urea breath test is very useful, not only for the initial diagnosis of the infection, but I would say even more important to confirm the eradication after treatment. So in the initial diagnosis, it would be used, this test, to the test and treat strategy we previously mentioned. And for the confirmation of eradication, it would be very useful in those cases where the endoscopy is not needed, which is the case in for most of the patients. So, I mean, only a very relevant infection is in patients with gastric ulcer. You all know that the endoscopy should be repeated to confirm the healing of the ulcer and rule out the presence of a gastric cancer. But in most of the other scenarios, clinical scenarios, the endoscopy is not necessary to confirm eradication. So on the other hand, the stool antigen test has also a very high sensitivity and specificity, more than 90%. And this accuracy is, very similar compared with the breath test. However, the results are more heterogeneous. So it is considered the selection, the election, the technique of choice when the breath test is not available. And there are two key aspects that I think are valid for both methods, for the breath test and also for the stool antigen test. And the first one is that we should perform these tests minimum at least 4 weeks before, 4 weeks after finishing treatment. And a second key point is that we should stop the antibiotics at least 4 weeks before the diagnostic methods is used, and at least 2 weeks before PPI have been taken. So if the patient is taking PPIs, we should stop these medications at least 2 weeks before the test is performed. So finally, as we have previously mentioned, the serology is a worse method because the accuracy is lower and it should be validated locally. And as we previously mentioned, it is not the case in most of the countries. And finally, I would like to emphasize again that this test, the serology should not be used to confirm H. pylori eradication.
If it is recommended in all cases to confirm the eradication of H. pylori infection after treatment?
The response here, I think, is again yes. And we have again several arguments, several reasons. So the first one is that I think the efficacy of the treatment at present is far from 100%. So there is another reason which is that it is an imperfect correlation between, on one hand, the symptoms, the clinical symptoms, and on the other hand, the infection itself, in a double sense. So on one hand, we see patients where the eradication with the H. pylori has been eradicated. However, they don't improve symptomatically. But on the other hand, we also have symptoms where the eradication has failed. However, they improve a lot symptomatically. There are another argument, which is that fortunately, we have, at present, we have several non-invasive methods that we have seen. And they are simple, they are relatively cheap, and they can confirm easily the eradication of the bacteria, such as, for example, the urea breath test or the stool antigen test. A fourth reason is that if we don't confirm the infection and the patient remains being infected, I mean, if the patient had a peptic ulcer, then he or she will continue being in risk of having complications such as peptic ulcer, and therefore the complications of this ulcer could appear in the future, and the patient will still be in risk of having gastric cancer. And finally, I think there is a final reason, and I think in my mind that most of the patients, hopefully, they would like to know whether the infection has been eradicated or not.
The H. pylori eradication treatment of choice, in your opinion?
Well, I mean, theoretically, the choice of the treatment should be performed based on the sensitivity and the antimicrobial sensitivity and the susceptibility of the bacteria, H. pylori infection. However, this strategy would require performing an endoscopy in all the patients, and therefore, obviously, this is not feasible. We should remember always that the test and treat strategy that we previously mentioned and is including is using a non-invasive test, and this is the recommended strategy in all dyspeptic patients, or in most dyspeptic patients. And therefore, the choice of an empirical treatment based on the local pattern of resistances or based on the local efficacy is the alternative that should be used in clinical practice in most countries. So at the present time, we consider a treatment effective, an eradication treatment effective, when the percentage of cure, the cure rate is higher than 90%. So at least 90% eradication rate. And we consider that a geographical area is considered to be a high resistant, high clarithromycin resistant area when this cutoff point is higher than 15%. So in areas with low clarithromycin resistant rates, that is lower than 15%, which is the exception nowadays, we still can continue using the standard triple therapy. That is a combination of a PPI, clarithromycin, and amoxicillin. We can also use a bismuth quadruple therapy, including a PPI, bismuth, tetracycline, and metronidazole. However, in areas with high clarithromycin resistance, that is higher than 15%, which is the rule, is the case in most countries, I mean, the treatments of choice will be the bismuth quadruple therapy previously mentioned, and also the non-bismuth quadruple therapy. That is a combination of a PPI, amoxicillin, clarithromycin, and also metronidazole. So I would like to emphasize that the standard triple therapy, that is PPI, clarithromycin, and amoxicillin, should be abandoned in the majority of the countries because it simply does not reach the threshold of 90% eradication rate we previously mentioned. That should be considered the cutoff point to consider effective treatment. So we can conclude, and this is the take-home message here, that the golden rule here for the selection, for the choice of the empirical treatment is to use what it is effective locally. And to do that is fundamental, is very important to review in a regular basis what is the effectiveness of each treatment we use in clinical practice.
Okay. How important is and how could be improved the adherence to H. pylori eradication therapy?
Well, the success of the eradication treatment will depend obviously on the resistance of the bacterial resistance on one hand, but it is also very important the compliance with treatment from the patient's perspective. So it is clear that all the eradication treatments are associated with adverse events, and in fact, this frequency is quite high. Between 30 and 40% of the patients will suffer adverse events, the most frequent being the gastrointestinal adverse events. However, the majority, most of them are mild, and the so-called serious adverse events only would appear in less than 1% of the cases. So therefore, I think it's very important, it's fundamental, I would say, to explain detailedly to the patients that the adverse events are frequent, this is true, but they are mild in most of the cases, and therefore the patient should comply with the treatment and should complete 100% of the medication. And finally, I think it is highly recommendable to prepare information sheets or handouts explaining how the patient should take properly the medication.
Thank you, Professor. The last question that I have is, can patients be reinfected with H. pylori after the eradication process?
Well, here I think that the first thing is to clarify the terms. So the general term is recurrence of the infection. And this could be a true reinfection where there is another completely different strain which is infecting the stomach of the patient. But this could be also a recrudescence, which means that there is, it is the same strain, the same H. pylori strain, which is infected again the stomach of the patient. So the true reinfections, in most of the cases, they appear 1 year after the eradication. So the rates of the true reinfections, they range depending on the country. So in developing countries, this rate could be quite high. Almost 10% of the cases patients can be reinfected. But in patients in developed countries, the reinfections are exceptional, only 1% approximately. So for example, in Spain, we performed quite recently a big study, including 1,000 patients with a long-term follow-up of approximately 5 years, and the reinfection rate was approximately 1 or 2% only. So therefore, I think it is not necessary to repeat the diagnostic test periodically, so over and over, for example, in a yearly basis. And we should only repeat the test when the symptoms reappear. In this case, to rule out the presence of a reinfection.